Welcome back to post-concussion syndrome. We are on video 4. So this is for my athletes. Again, we're reminded of the physiologic, cervicogenic, and vestibulo-ocular PCS subtypes. Today, I'm going to review video 1, 2, and 3, and then dive into cervicogenic and vestibulo-ocular. So in video 1, I presented Rowans' law as well as the energy crisis. Rowans' law is graphically depicted here as the hit, stop, sit rule, and especially if there are any of the symptoms present, it's important that a player must sit out the remainder of the game. The energy crisis is that increased ATP usage and decreased ATP production, meaning more energy is used, less is produced, so we have that energy crisis when there's a concussion. Video 2 was again focused for the athletes. So this is why it's so important to report symptoms early. And I presented a study from the University of Florida NCAA athletes that highlighted early reporting, saw better results and a faster return to play. If we don't remember that, please go check that video out. So avoiding deconditioning. For athletes to exercise early is better because it avoids this deconditioning, which is that autonomic deregulation and disproportionate response to CO2. Basically increasing symptoms. Video 3 was specifically for the clinicians, talking about the BCTT and some of the important things to think about or bring with you, such as the VAS chart and the RPE chart, as well as stopping criteria for the test. And now we're jumping into vestibulo-ocular and cervicogenic PCS. So to properly orientate our body in space, we need to have proprioceptive input, visual input, and vestibular input. Proprioceptive is more related to our muscles and can also be specifically related to some of the muscles in our neck. Visual input from our eyes and vestibular input from little canals that are just inside our ear. I'm going to go over this a bit more in a few slides, but we need all three of these working together and working together well in order to properly orientate our space. If any one of these is upset or feeling off, then we may feel symptoms and especially dizziness symptoms. So I have this side by side here for vestibulo-ocular and cervicogenic. So comparing symptoms, if we read the first one, mild to moderate headache, dizziness, fogginess, exactly the same over here. Now, the second line is where we start noticing differences. For cervicogenic, we may notice postural imbalance, neck pain, stiffness, and decreased range of motion, which makes sense because cervicogenic is our cervical spine, our neck. Vestibulo-ocular, we may feel eye strain, intermittent blurred vision, difficulty focusing or concentrating, as well as intermittent vertigo during certain head positions. This makes sense because it's our eyes and the thing that gives us our balance inside our ears. So for vestibulo-ocular, some of the triggers are reading and focusing, and cervicogenic, some of the triggers are movement and sitting out. Of course, this is not an exhaustive list, but I'm just trying to highlight the main differences between the two. So our vestibulo-ocular, this is our vestibular system. We have two of these on either side of our ears. So these little canals help us orientate ourselves and feel balanced. So you can think about it like that air bubble and the little measuring on the ruler. When you start moving the ruler, the air bubble moves around. Similar thought process, not the exact same, but similar. And of course, the ocular part of this word is our ocular system, or our eyes, and just how our information goes from our eyes into our brain. Our cervicogenic, so this is our cervical spine here. And what I'm highlighting here is that there's a plethora of muscles. And if any of these are dysfunctional or have any damage, they can send specific pain patterns highlighted here in red. So this specific muscle is our SCM. If anything's damaged, then it can send pain to this part of our face and head. So we may have headaches and think it's a concussion, when in reality, we just need some manual therapist to work on this muscle. This picture here is to highlight how many different ligaments are in just a small section of our cervical spine, which is why it's so important to get proper treatment so that somebody knows what's going on. So I want to talk about how to improve some of these things. Now, this is vestibular therapy improves symptoms. So a good quote is 23 to 81% of concussion patients report dizziness. This is a huge range, but it's worth noting because at least some people are going to be suffering from dizziness after concussion. Now, specifically, this was a pilot study, and pilot studies are not always the best pieces of information, but this was worth noting because we're looking at those who had early vestibular therapy and their days to return to play. Also, days to symptom resolution, okay? So days to symptom resolution, we saw a 124% increase if people saw a vestibular therapist late after injury. And the cutoff point was actually 30 days. 30 days from the late to early group. With regards to return to play, if you saw a vestibular therapist early, you were much more likely to return to play early. Now, some of the limitations of this study, it was a pilot study, and there also could have been referrals for other treatment. So we can make note that pilot studies are not as good as an RCT. So you can imagine what's coming next. An RCT on cervicovestibular therapy. Just breaking up these words, cervico and vestibular are cervicogenic and vestibulo-ocular. So the two groups we have in this RCT were obviously the control and the intervention group. And in the control, they did these exercises. So range of motion exercises, stretching, postural education, and return to sport guidelines. The intervention group got all of these plus cervical spine therapy, vestibular therapy, ocular rehab. So we're looking at the clearance proportion after 56 days of treatment. So this blue line here is the control group. At 56 days, we had 1 out of the 14 people in the study cleared. So if we go back, this is our control group. All they did was range of motion exercises, stretching, postural education, and they followed a return to sport guideline. Now we compare that with the red line, the intervention group, and we see 11 out of the 15 people are cleared. Hopefully, this should highlight the importance of getting treatment. Now, some of the words are confusing and sometimes it's hard to keep track of what's going on. The most important thing is that you're seeing a trained professional so that they can look at all the subtypes: physiologic, cervicogenic, vestibular-ocular. So when we're talking about the treatment group in that RCT, I want to share this quote first. And that's, there is no clear and uniform guidance describing an active physical therapy treatment approach for concussion-derived dizziness. That's true. There's no set guidelines. But what I want to highlight is that in the treatment group, these were some of the exercises done. While there may not be a specific guideline, there are a lot of possibilities. So there are a lot of active treatment options that can help those suffering from a concussion feel better. So in the next video, I'm talking about the clinician's toolbox. I'm going to be talking about baseline and sideline testing, as well as diagnosing and post-injury care. Thank you so much for watching today, and I hope to see everybody soon.